Thank you, sir, for the grand opportunity. Good morning, ladies and gentlemen. Greetings and regards from the land of Lord Jagannath. Before we go to the management and the nucleus management in particular in small pupils, let's just try to outline the causes and what causes the small pupil occurrence in those situations. Basically, these are all systemic conditions. PXF, pseudoexfoliation syndrome, causes a generalized atrophy and muscle deposits on the dilator, both the dilator and the sphincter and the sphincter muscles. That's the reason why it causes small pupil. IFIS causes a dilator muscle atony and thereby causes an atrophy of the same. Synechia or membranes mechanically restrain the pupil from getting dilated, and that's the reason why they cause small pupils. Sometimes it's age-related because tissue atrophy is generalized. All tissues of the body get affected, including the knee capsules and the ligaments. That also doesn't spare the muscles. And in diabetes, there occurs metabolic changes in the sarcomeres for which it becomes kind of rigid. The resurrective measures, these pharmacological agents, we now have excellent intracameral agents too, which cause a pupillary dilatation or maintain that if it's even slightly dilated. OVDs, there are different types of super heavy OVDs, and they cause a mechanical, they cause a bulk and sit on the pupil to mechanically dilate it. However, it doesn't stay for too long. Cyclitic membrane, if it is there and restraining the pupil from getting dilated mechanically, it must be peeled. Synechiolisis, if that's the reason for the small pupil to come in, it must be lysed. And of course, there are expanded devices, and we will take a look at the expanded devices, and we're very proud for being Indians because 3 of those expanded devices are from India. This is the first case wherein there is a cyclitic membrane and there's synechia as well, because this is a uveitic cataract. So I'm doing the synechiolysis first and then peeling off the cyclitic membrane. Just look at the pupil, the way it behaves after that. The restraint is gone, and the moment you put in the viscoelastic, it just expands, so it doesn't need any pupillary devices. But if we would not have done those initial procedures, taking 10, 15 seconds time, then we would have had probably to use some expanding device. This is the age-old true friend of ours, the iris hooks, polypropylene hockey stick-shaped hooks, which go in through the side port incisions. The way they should go into the eye should be parallel to the iris surface. Then they should be rotated, and then the stopper should be tightened, and it produces a rectangular kind of a shape. And the 5th hook is optional. It might be applied subincisionally or not, but this is the way it should go in, and the reverse should happen when they would come out. The most trusted pupillary expansion device in my practice is the Milligan ring, and I'm sure that a lot of people would agree with me that this is the most solid ring, the most robust device that dilates even the most rigid of pupils. Made up of polypropylene, it has got 4 hairpin scrolls. 3 of them are actually engaged as the ring comes out of the plunger, and the 4th ring has to be engaged later on, introducing a Sinskey hook from the side port cannula. It produces excellent pupillary dilatation. There are 2 types, 6.25 and 7. 7 is a little more difficult to maneuver, but 6.25 is a fantastic device. This is the first device that we would be talking about, which is from India. This is the Gupta's ring. It's, the material is PMMA, but the disadvantage with this is you need a 2.8 millimeter section to put it in. It doesn't come as a preloaded device, so you have to load it just like an IOL in a butterfly cartridge. And the other thing is there is a junction in one of the shafts, and the junction sometimes snaps inside the eye, so it might just injure the. So technically speaking, the build quality is not as robust as the Milligan is, but it looks like the Milligan and mostly works like the Milligan as well. This is the Gupta's ring. This is the B-hex, the most slender of those 5 devices that we would be talking about. It gets in even through a side port. Polyamide made, extremely thin profile, and it doesn't have 2 vertical profiles. It has only 1 vertical profile. There are alternate flanges which need to be put into the iris, underneath the iris. Produces are 5.25 to 5.5 millimeters dilatation, but the disadvantage with this is too slender a device to have any tensile strength. So if it's a very rigid pupil, you have to stretch the pupil first mechanically before putting in the B-hex. Otherwise, it doesn't work, and the pupil also becomes very distorted and asymmetric in very rigid pupils. The last of the, this is the Visitec eye ring, not from India, of course. This is a polyurethane ring, and it's got hinges. So when it goes into the eye, if you look at the hinges, the way it unfolds, beautiful device. The only thing is the width is a little thicker than where I would want it to be, but it's very, very flexible indeed. It's got a groove all around it, and there are holes holding which you can engage it in the pupil. The most rigid pupils are very effectively dilated, but because look at the way it bends. Because of the hinge effect, it bends really, really hard and goes right to the center of the pupil. The last of these devices is called the iNova, which has come recently from Aurolab. This is a silicon device, and it's a round device, preloaded, but the plunger doesn't work very well. It sometimes opens in a figure of 8 pattern inside the eye. But once you engage, this is the device that causes the most circular pupil inside the eye once you get it engaged. The other devices make the pupil somewhat rhomboid or rectangular, but this renders the pupil very, very circular. Again, the disadvantage is it's a very bulky device. So if you have a shallow AC, this is not the device to be used in the eye. The question is, once you have a dilated pupil, the nucleotomy is a routine nucleotomy. Soft, hard, moderate, whatever. But if you do not dilate the pupil, until what point you should not be dilating the pupil? In my opinion, that would vary from surgeon to surgeon where your threshold lies. But if you have an ATIL to be placed, a toric or an EDOF or a trifocal, different lenses have different diffraction or wavefront designing surface changes. And if you have a pupil that does not react to light the way it should postoperatively, then you might not yield the same desired result. So in some cases, you should be able to handle the nucleus even with a small pupil just to keep the aperture function intact postoperatively. So this is one such case. And if you want to do the nucleotomy in the presence of a small pupil, there are a few tips. The second instrument plays a pivotal role here. When you're chopping it, it should go rubbing against the nucleus so that you don't engage the anterior capsule, because some part of it will be blind. We all know that. And once you disengage, the second instrument goes and kind of levitates the nuclear portions out of the bag. And the second instrument's positioning should always be ahead of the nuclear probe or the phaco needle, because the other risk which is unforeseen when you're beginning your nucleotomy is the moment there is a vacuum, the phaco needle gets released of the nucleus substance, the residual vacuum pulls the pupillary margin. So it's very close to the phaco needle. So that's something you should protect that with the second instrument. And after the nucleotomy is finished, the other procedures also can be done in similar manner, retracting the pupil with the second instrument. So if you are handling the nucleus or thereafter the other tissues in the presence of a small pupil, the left hand, which is usually the non-dominant hand for most surgeons, has to play a pivotal role for its positioning and doing the procedure effectively. Thank you so much for your attention.